Hi, I'm Dr. Rajan Segar from University of California, Los Angeles. The question in front of us today is, why is connective tissue disease pulmonary hypertension so difficult to treat, and what are the general approaches to medical management? So the difficulty in treating this entity really lays in the heterogeneity of the disease to begin with, and all the different mechanisms that lead to pulmonary hypertension in systemic sclerosis. And the other factors are the patient population itself and some of the comorbidities. So for instance, these patients tend to be older. They tend to have a clinical condition, i.e. systemic sclerosis, which can be confounded in terms of the pulmonary hypertension, can be confounded by the presence of some degree of interstitial lung disease, which is fairly common. And trying to tease out how much lung disease is there and whether the lung disease is driving the pulmonary hypertension versus having more minimal lung disease and having more of a PAH group 1 phenotype is really a clinical conundrum sometimes. These patients are also at risk for left ventricular diastolic dysfunction, and so they're at risk for the group 2 pulmonary hypertension phenotype. And then they also have issues related to confounding musculoskeletal issues, so making assessments on their functional capacity may be limited by some of their musculoskeletal complaints. They often tend to be deconditioned. There's data suggesting that the musculature of these patients may be compromised at a myofilament level. There's also data suggesting that their diaphragms may be dysfunctional compared to other types of PAH patients. And in general, there may be a late diagnosis. Patients may present late for various reasons, and the diagnosis may be delayed as well. So how do we base our therapies? Well, we first assess risk and determine what type of patients in front of you. And we use several parameters, and I refer you to the ERS-ESC guidelines, which highlight how we assess risk in terms of determining low risk versus high risk, which really leads to what we offer the patient in terms of therapeutic options. And this list of parameters to determine risk include features based on clinical presentation, based on hemodynamic assessments with right heart catheterization, based on echocardiography, and based on serologic markers such as BNP. And once we assess risk, we can consider whether we're going to introduce a single therapy, which single therapy that may be, or consider a more aggressive combination therapy approach. And of course, if the medical therapies lose value or if there's progression of disease, other potential therapeutic options may include atrial septostomy, which is often a bridge to the ultimate option, which is lung transplantation. Of course, there are investigational protocols which are always in place and should be considered as well for these high-risk patients. The recommendations for the connective tissue disease PAH group, based on the ERS-ESC guidelines in 2015, recommend that the treatment algorithm for connective tissue disease PAH is no different from idiopathic PAH. Again, this is a grade class 1 recommendation. The other class 1 recommendations include resting echocardiography as a screening tool in asymptomatic patients with systemic sclerosis, including annual echocardiography, diffusing capacity, and biomarkers such as BNP or NT-proBNP. And in cases of suspected PAH associated with connective tissue disease, the recommendation is for right heart catheterization. Again, these are all class 1 recommendations, although with level grade C evidence. The therapies available are listed here. These are FDA-approved therapies for the use in the United States. You can see that all the therapies come from one of 4 categories, either endothelin receptor antagonists, medications within the nitric oxide cyclic GMP pathway, medications within the prostanoid or prostacyclin analog pathway, and finally, drugs within the prostacyclin agonist pathway. So in the treatment of patients with connective tissue disease associated PAH, we have to recognize that these patients are often underrepresented in clinical trials. They represent usually 1/5 to 1/4 of the patients that we study in any given PAH study. It's also very clear that the treatment effect, whether it's monotherapy or combination therapy, seems to be less robust in terms of the benefits compared to their idiopathic counterparts. And we have to remember that the international guidelines, despite all of that, support treating patients perhaps more aggressively in this more unfortunate cohort of pulmonary arterial hypertension related to connective tissue disease. And those aggressive approaches, including combination therapy, may be more necessary in such a population. Thank you.